APM report number 114. It has a lot of examples, a lot of scenarios going from simple cases to more complicated cases. What we're going to discuss here today is when would you pass a plan or when would you fail a plan? When the physicist says this plan doesn't proceed for treatment or this plan, can proceed for treatment. So we're all starting here with, you wanted to start doing 3D CRT in your clinic, tamam? Or maybe you want to expand on it. I know a lot of you are in different stages. Some of you have already started, some of you are very advanced, and others are, just about to start or maybe haven't started yet. So as a quick reminder how the matrix works. First of all, you have to make sure that your TPS is commissioned properly. TPS هو Treatment Planning System. And many resources were discussed during the course with you guys. Some of them are AAPM reports, the American Association of Physicists in Medicine, and a lot of them could be IAEA. IAEA reports are available and they are available for free on the website. So let's say you're already doing 3D CRT, tamam, but you want to expand and do something extra. Maybe field-in-field technique, you didn't do it before. You have to make sure that before you start implementing anything new, that your planning system can handle it. So maybe if you're already doing three-dimensional planning and you want to add a different type of technique, maybe expanding on a technique, you don't have to do full commissioning, right? But you don't apply it immediately. You have to take maybe 2 days, 3 days to make sure that your planning system is giving you expected results and they can be verified. Steps number 2 and 3, they could be in the same step or separate. We talked about it, I think, way early on, lecture number 5, I believe, that training, you have to train all staff. And this is part of what you're doing. You're taking a very positive step. You are being proactive. You're learning, you're training. And also, we talked about you have to prepare clinical protocols. Those really should be specific to your own needs. For example, مثلا breast we call it السهل الممتنع, تمام? So breast is easy and difficult at the same time. Some clinics would use monoisocenter for breast treatment for both tangential and supraclavicular. Some clinics do tangential AP supraclav and they do a PA boost. Other clinics don't do a PA boost. Some clinics use, the old technique of, not the old technique, I'm sorry, like the classical technique of an isocenter in the middle of the breast with angulated gantries. Some clinics are using the chain around the breast. This is what we learned during the regular simulation. So you cannot have a protocol from one clinic to apply to the other clinic. You have to make your own protocol based upon your own practice. What would you accept in your case? And then make sure that whoever is doing breast planning and breast simulation in your clinic, they're all following the same protocol. When you have things written down, documented, and everyone is doing the same thing, you have less room for error. And with 3D CRT, the level of error becomes much more than we're doing 2D planning. So you really want to make sure things are uniform and homogeneous. Last thing is machine and plan QA, right? So you want to make sure that your machine can handle those extra complexities. The tolerance of a machine, I would expect that is only treating palliative cases might be a little bit loose than the tolerance of a machine that is treating 3D CRT or IMRT. Okay, so you also have to examine your machine. If your machine is older generation, cannot give you the expected 2 millimeter intolerance, maximum 2 millimeter intolerance for whatever you want, then maybe you don't treat 3D CRT on this machine. Plan QA. And plan QA is what we're talking about today. How would you make sure that the plan is proper? When would you approve that it goes further for treatment? Start session 1 of treatment, and when would you stop it? And what happens if the plan QA does not pass? What are the practical things that you need to do? Right, so we'll be discussing plan QA. So this lecture is about 3D CRT Plan QA. The person who does Plan QA is the physicist. So the planning itself could be done by a dosimetrist. Some clinics would allow therapists to do some sort of quick plans, maybe APPA or some sort of conventional planning. And we have some clinics have the physicists themselves perform planning. So it does not matter who is performing the actual planning, right? Now, once this planning is finished, then a second checker, who should always be a physicist, right? A dosimetrist cannot be checking a plan, even if, senior dosimetrists. Senior dosimetrists can check among each other. Senior dosimetrists can check the plan of other dosimetrists, but it will not be approved to go for treatment if it doesn't go through a physics check. And I just want to, highlight this. Right, so the second checker of a plan has to be a physicist. The question is, when would you check the plan? Would you check the plan before or after the patient is brought to first session? Well, of course, it has to be before. The idea is the patient is not called for treatment if the plan is not approved by a physicist to have met all quality matrix, like all the QA indices you have in mind. Now, the other question is, when do you check the plan? Before or after the radiation oncologist approves it? According to my experience over the so many years before and working in different hospitals, some hospitals, they say, I want the plan to be second checked by a physicist before the radiation oncologist approves it or look at it. The idea is that when the radiation oncologist looks at a plan and finalize it, and that's it, this is what I want to treat the patient, then they don't want to have any changes coming to the plan. So if there anything that's wrong with it, if you have any parameters that need to be changed, the computer output is verified before the radiation oncologist approves the plan, right? So once he or she approves it, that's it, plans proceeds for treatment. I have also worked in hospitals where the second checker looks at the plan after the radiation oncologist approves it. And the rationale was, well, maybe the DVH is not appropriate. Why should I waste physics time looking at the plan? I mean, second checking a plan. Maybe the isodose is not appropriate. If the radiation oncologist does not approve the plan, and the dosimetrist or planner has to do it again, then why are we wasting, physics time? So 2 out of 3 hospitals that I worked in, they go with this method. Say, planning is finished, radiation oncologist either agrees or disagrees with the plan. If the radiation oncologist doesn't like the plan, it goes back for planning, so another loop for planning. If the radiation oncologist likes the plan and approves it, then it goes for physics second check. And it's really up to you. Again, I leave it to each clinic to decide when the second check should happen. Now, we all agree that the second check should happen before the patient is called for the first treatment session. But is it going to be before or after radiation oncologist approval? This is according to your practice. So, hello? Okay. And we're doing second check. When a physicist is performing second check, we're looking at 2 things. We're looking at dosimetric parameters, and we're looking at computer output. So dosimetric parameters, was the appropriate energy and beam angles used? I'm going to stop here and share something that was recent, where we have a brain plan. Tamam, let me just try to write something quick here. So this is supposed to be a brain. Hold on, this is not a brain. Okay. So let's say I have a cross section of a brain near the eyes. and there's a tumor around here, right? And the radiation oncologist approved the plan. The isodose lines were nice, they were conformal, they were covering the GTV and PTV nicely. The DVH of the PTV, GTV, brainstem, not the parotids, I'm sorry, the temporal lobes, everything, and the left eye were all looking good. So someone might say, why should a physicist, right? Why should a physicist bother with looking at the dosimetric parameters, energies, beam angles, and isodose line, if the radiation oncologist already approved it? And the answer is because sometimes minor things might not be of importance to the radiation oncologist, but they are of importance to overall treatment. And most of the time, the oncologist is very concerned and concentrating his or her effort on the conformality and the high doses that they forget about low doses. In this particular case that I'm mentioning, and I said it happened, very recent, everything looks good when you're looking at the high isodose conformality. DVHs looked really, really good. One thing that caught my mind, I was doing a second check for the plan, is that the dose to the right eye was way higher than the dose to the left eye. So the left eye DVH dose was 6 gray and less. The dose to the right eye was I don't want to tell you how high it was really high. Actually, it should have been caught by the dosimetrist and the radiation oncologist, but it wasn't, as I said, because mostly they're looking into the high doses, the 100%, 90%, 80%, and any hotspots. And when I looked carefully about what could cause the right eye to have higher dose, I mean, the tumor was fairly far away from the right eye. One of the beams had an entry through the eye. Actually, this was an ARC treatment. This was a VMAT treatment. It's not 3D per se, but it was a VMAT treatment. And there was a good 20 degrees. So there's a half arc going like this. And about 20 degrees were going through the right eye. So I said, I contacted the planner, I contacted the radiation oncologist, and this is why you need to have a second checker, a physicist, to look at all these parameters, even though the plan has already been approved by the radiation oncologist, right? Because you might not notice, some low isodose going there, but these angles, these beams going through the eye, if they were omitted, they will not change the plan quality. And we have to make sure that the patient receives as low as reasonably achievable. The ALARA principle not only applies to radiation safety for shielding, it also applies for saving the critical organs. There's absolutely no reason for this particular case to go through the eye, for example, right? Other things that the second checker has to look into when you're talking about 3D CRT plans is where the point of prescription is. And this happens very frequently. I should say in breast cases most of the time. No, I shouldn't say most of the time. From my personal experience, I usually return about 10% of the breast cases where the point of prescription is right there at the chest wall lung interface. I don't know why they do that. We talk about it all the time in our clinic, but sometimes, they're too in a hurry, they want to finish quickly, etc. And there is a physics reason why we don't put the point of prescription at interfaces. And we discussed that in the ICRU lecture, that the planning system cannot calculate accurately dose at interface. The planning system will give you some result. It will show you monitor unit. It will show you some dose, but those will not be correct doses. So that's another thing that the second checker should keep an eye on. The radiation oncologist will not look at where the point is located. The radiation oncologist will just look at the isodose distribution, the DVH, and making sure that the plan objective from his or her point of view are met. But we have to make sure that these plan objectives are calculated correctly. So that's what we're doing when we're doing. Hello? Afwan, I can hear some background. If anyone wants to ask a question, please write it down in the chat. Dr. Sarah, she can stop me anytime, please, Sarah, and let me know if someone has a question. Now
sure, I think that was just like
background noise.
A mistake, okay. Yes, yes. Thanks.
So now, another thing is computer output. Tamam? And just because things are computerized, it doesn't mean that we have to believe the output of the computer. Remember that the computer will give you a term called gecko, garbage in, garbage out. If you feed the computer something wrong, it will give you an output, but this is the wrong output. So you have to make sure that the output of this plan is also correct. You have to QA it. And for 3D CRT conventional planning, the output is the monitor unit per beam. So the planning system is telling you for every beam, there's a particular monitor unit. And now the physicist has the task of verifying this monitor unit. طيب السؤال, how do we do that? Let me just... Anyone know how we do that before I continue? How do we verify the monitor unit of the planning system? Any takers? No? Okay.
Feel free to unmute yourselves if you want to answer this.
So how do we make sure that the monitor unit is correct? What do we do? Well, I hope everyone knows that, unfortunately, us physicists, we have to perform monitor unit calculations.
Someone answered.
Oh, someone did. I'm sorry, I'm not looking at the chats.
Yeah, just now, actually. So Kauthar says they use an Excel sheet. Someone, I don't know the name though, says manually or via software.
That's okay.
That's good.
Yep. So that's absolutely true. So we have to, what we call, independently verify the monitor unit. And it is not an easy task. Once you go into 3D CRT and you have all those field and field, and you're using heterogeneity corrections, that is not an easy task. And this is the discussion of the report number 114. And here's another question, everyone. What is the allowed tolerance or agreement? Let's put it this way. What is the allowed agreement that you expect between the planning system and your MU calculation? 1%, 2%, 3%, 5%? What do you think? Okay, so someone said less than 5%. Okay. Less than 5% for everything or for certain cases? And if I have Hodgkin's, I'm treating a non-Hodgkin's lymphoma, APPA, this very complicated beam with so much blocking. Would I expect the same, 5%, 2% agreement compared to whole brain, for example? Masoud is saying 2%, and 02210 is saying less than 5%. Okay, so again, you can see that someone is accepting 2% and someone else is accepting, 5% or less. And it really depends on your clinic. However, it's good to base it upon some sort of publication. Thank you. No, it depends on the case at hand. That's good. So let's say it depends on the case at hand. What is the most disagreement you would go with? Okay, I was expecting someone to write something. So let's together, and this is really important for the radiation oncologist to pay attention to, because a physicist might tell them, this plan is not passing QA and I need to investigate it further. Please listen to your physicist, because if the output of the computer is not correct, you might be delivering the wrong dose to the patient. So the whole idea is we want to verify the output, because monitor unit is what the linear accelerator understands, right? You program the LINAC with the MU value. This is what gives off radiation. So we will look at TG report 114. And it basically, this report is very, very useful. And it's a very good reference. I really ask everyone, especially physicists, to read it. Now, it tells you the likelihood of errors in monitor unit calculation. And it's comparing manual versus full automation. So this is the degree of automation. L is low likelihood of error. M is medium likelihood of error, and H is high. Tamam? And as expected, at least from 1, 2, 3, and 4, if you're doing manual calculation, you are more likely to have errors in MU calculation. صحيح? Tray, there should be a tray in the plan, but you forgot to include it in your manual calculation. Okay? There is a wedge in the plan. Now, here's the thing. I could forget to put the wedge in my manual calculation, or I could put the wrong wedge. Instead of 15-degree wedge, I put 45-degree wedge. Or if I used the wrong direction, instead of it's in, it's out, so on and so forth. For everyone who is using an Excel sheet, you have to be careful that you are here. So this is manual. And for people who are using automation, fully automated MU calculation, then you would have less errors with this. If you have a third-party software, it means that you are pushing the plan from the planning system towards that MU software. And so a lot of these parameters will go through. However, automation also has its own unique challenges. So look at this. What if I'm using the wrong data set? So this is using the wrong data set. I'm sorry, this is automation for treatment planning. If I'm using the wrong data set, patient was CT simulated today, and then we discovered that the position was wrong. So we simulated her again tomorrow in the correct position, but the planner used the wrong data set. Or we use the wrong CT for a different patient. Then you're introducing a lot of errors here, huge error, because you're using the wrong data set. If you're using the wrong scaling for CT and MR images, and this is something you do when you commission the planning system, you have to make sure that the 1 cm is 1 cm on the images, 2 cm is 2 cm in the images, so on and so forth. When we have computer bugs, they are very high if you have a fully automated system. Kind of makes sense, صحيح? I am 100% dependent on a computer, and so anything could go wrong. There could be a virus, there could be some sort of a wrong operation in somewhere, and it affects this particular patient. It's not something systematic, it's just a bug that affected this particular patient. Few things are common to whether you're using manual or full planning. If you have the calculation point in the wrong place, right? This should be noticed from the beginning. And if the planner forgets about it, or they don't realize they have it in the wrong position, and again, it happens, and it's happening, it's happening currently where I work, most of the time, as I said, with breast cases, because they're very challenging, especially if they are chest wall. You have to really use your, good imagination to find a good location for that prescription point. If the chest wall was literally skin over bone, where would you put it? Changes to already approved plans. This is very important. Excuse me, my mouse is not steady. In 2000 and what was it? 2007, I think, where we had the IMRT case in New York. A patient was going through IMRT treatment, received, I think, first fraction, and then the plan was redone. So the physician wanted to revise the plan and change the plan, but then the physicist didn't do the QA on time. The new plan was delivered for, I think, 3 fractions before the physicist did plan QA. And by that time, they realized that the monitor unit of the IMRT plan was being delivered, but the MLCs were not moving. So, and this was a head and neck patient. In about 3 fractions, the patient received lethal dose to the cervical spine, developed quadriplegia, and later passed away. And this happened because there were changes made to an already approved plan. And instead of stopping treatment, giving enough time for physics to do the quality assurance and make sure that everything is appropriate and proper. That they continued with, I said, oh, patient already received first fraction or something like that. It will continue with treatment, and then the physicist can have enough time to to do the QA later, next day or next night or whatever. In 3D CRT, changes to plan most likely will not lead to severe outcome to a patient if it goes unchecked, but it might lead to either under treatment or over treatment. So it will be a radiation incident. It might not be very severe, leading to patient death, as in this case, but it still might be, severe enough that it will alter the management of patient. I cannot really talk enough about paying attention to changing plans that are already approved. In the last 4 months, we had one near miss situation. A near miss is when a mistake reaches the treatment machine, but the patient is not treated. Or sometimes people call it a good catch. And it had something with changes to an approved plan. So a patient received few fractions, let's say on plan A. And then in the first week, the physician wanted to change the plan. Everything was done properly. So there was enough time for replanning and enough time for quality assurance. So, patient was put on hold for, I think, 2 days. What happened is that at the final step, when the new plan was approved, so now it is appearing on the machine that this is a plan that I can deliver to the patient. The planner and the physicist who did the second check, both of them forgot to unapprove the old plan. In this particular system, if you approve a plan, it becomes available for treatment. So for this patient, there was 2 approved plans. One is the old one that is no longer should be used, and the other one is the new one, the new changed plan. People who discovered it with the therapist on the machine, because as the physicists do second checks, so the therapist, the radiation therapist, فنيين الأشعة, the technologists, they also should be doing their own second check as well. And one of the things that the therapists check for, any changes that happen to the plan. They already had a note that this patient is on hold because of plan revision. So they already know. So in this case, the therapists were better than the planners and us physicists. It really takes the entire team to second check each other. They were able to realize that they have 2 approved plans. They called physics again. And what we do is that we had to complete the old plan early and make sure that the fractions received from that old plan are added up to the new plan. And we had to make sure that the fractionation itself is correct. So the record and verification can continue counting the correct fraction numbers and correct those. Making sure that approved plans, that changes to approved plans are noted, is not only for 3D CRT or conventional, it is for all patients, IMRT, SRS, SBRT, everything. Afwan?
Sorry, Dr. Shada, yes. I was wondering if the table can be also explained in Arabic, this table.
طيب, I can go quickly point by point بالعربي, but it's better you have, Mayada, you have the reference. We sent it to you, email. والدكتورة كمان أرسلته على الواتساب جروب إذا أنتم بالواتساب جروب. It's better إنه it's better that you in your clinic when you have enough time that you translate this one by one. I can help you now with the quick verbal translation. فرقم 5 تقول لك الشعاعي الفيلد سايز بدل ما نحط مثلا 6 أو الاستخدام الخاطئ لنسبة البلوكد فيلد. Kauthar did not get it by email. Okay, so I want to ask Faye. Faye, some people did not get the references, APM report 114 and 71 by email. Can you please send it to everyone again? بس الآن بعثت مسج
وصلوا هم دكتورة طلبت من عندك لأنه أنا ما
ما هو يعني الريبورت شويه طويل، بدل ما تترجمي كل التقرير ترجمي ممكن نساعدك انا والدكتوره ساره بالترجمه، ما في مشكله ابدا، بس يعني مثلا او يعني
للجداول بس مو اكثر.
طيب I'm going to speak in Arabic right now, explaining what I just been talking about for the last 5 minutes. So for those who don't speak Arabic, I'm not saying anything new. في حساب المونيتور يونت، تمام؟ فبيكون عندي medium، يعني احتمالية أو بدل ما أستخدم السي تي للبيشنت للبوست مثلا، هاي الأمور الطبيب أو الطبيبة، لأنه صار في حادث بنيويورك بال 2007 تم إعادة وصار خطأ بدون البلاننج والكواليتي أشورنس، وما اكتشف الخطأ إلا بعد 3 أيام، وكان EBRT planning. تمام يعني you spend time on it a little bit وتحاول أنت تترجميه.
يعني وضحت، شكرا.
تمام، وأي شيء بالإيميل ممكن شوية نتأخر بجواب الإيميل عشان
الله.
تمام.
اوكي.
الآن the next thing we have to do is
إن شاء الله.
that
شكرا دكتورة.
عفوا، هلا حبيبة قلبي. We have to put a checklist for the QA. تمام.
Sorry, Dr. Shada. Before we move on, I think this is an important question from Masoud. If there's an error in MU for any reason during treatment, either increase or decrease in MU, what do you do basically in this situation, I guess?
تمام Masoud, we're coming to this in the next slides. I'm talking about this today.
Thank you.
Okay. So now, how would you do the QA checklist or the plan QA checklist? So a second physicist, the second checker is looking at the plan. So we talked about beam energy, we talked about gantry, entry of the beam, we talked about prescription point. It's always better to do your checklist based on this table. Look at the things where are medium. طبعا بالحياة المثالية you need to add everything in this table, but it doesn't make sense. It's practically not possible. So I would suggest to do your checklist depending on any medium likelihood of error and higher. So if it's medium and high, I include it in the checklist. So that when you have someone doing the second check, they go, oh, I'm checking this, يحط صح, I'm checking this, يحط صح, إلى آخره. So 2 checklists should be made. The first one is for the physicist. So physicist, you have the task of checking plant quality, the dosimetry quality, isodose coverage, DVH, and as we talked about these things, and as well as everything that is in the table that is medium or high risk potentially, and the monitor unit as well. The second checklist is for the therapist. The therapists are really our last line of defense. A lot of the good catches, لما نحكي good catch أو it's a good catch or that reached the linear accelerator but the patient wasn't treated, most of these good catches are done by the therapists. It's very important to have a timeout on the machine. تمام? A timeout, by the way, not only for new patients and new plans. You should have a timeout every day for every fraction, even if this was the last, fraction for this patient. This is 25 out of 25 fractions. And I will let you know why we need to do that. If you are a busy department, communication will most likely break down. يعني we always say we don't have any problems, we don't have any incidents, we have a perfect life. Just because you don't catch an error doesn't mean it doesn't exist. We do have in our own institution, myself and Dr. Sara, we work for the same institution. We have monthly, where we look at the errors and we send them to our chief of physics, we send them to the chairman, and we always discuss about them. And we have a recent checklist that was implemented in September because we caught, particular errors, particular mistakes were happening all the time. For example, in a fully automated environment, if someone forgets to click or initiate something, or if someone, as I said the example before, if I forget to complete a course that I'm not using anymore, or if I forget to unapprove a plan that is no longer used anymore, then the therapist on the machine will see something different than the planning intention. تمام؟ يعني إحنا إذا عملنا أي خطأ ولا نسينا نعمل شغلة, whether we make a mistake or we forget to do something, اللي يظهر عند تمام. And it happens not frequently, but it does happen that the physician or physicist, they change a plan, they make everything and they print it out. هذه in the clinics where they still use a printout, but they forget. You don't believe how many times this happened in a previous place where I worked. So a new plan is made, it's approved, it's gone through all the QA, but we forget to print out the new plan and put it in the patient file. So, this is a situation where we still are using files to communicate and deliver treatment to patient. So what happens on the LINAC, the therapist is still using the old plan because there is no new plan, no new papers in the chart of the patient. صحيح ما في. طبعا يكون في مثلا notes from the physician. If you go to the physician note, the physician would write a new plan, مثلا mask is too loose, or there's progression of a lymph node, a new plan is made with physics. If the therapist did not check all the notes, including physician notes, they will not know that there is a new plan. So there was a miscommunication here where the physician did write, a new plan will be made, but then someone forgot to put the paperwork in the patient chart, and the patient then received few fractions with the old plan. So even if the patient is under treatment and no one told the therapist that there is a replan, it doesn't mean that there is no changes. تمام؟ يعني الواحد ما يطمن. There should always be a timeout. Radiation therapy is like surgery. There should always be a timeout before treating your patient. مش بس the first fraction, for every fraction. So therapists, keep an eye on any plan revision, especially prescription, because sometimes depending on reaction, something very simple, patient develops reaction and in follow-up clinic, the physician decides to give the patient 1 week off from treatment. Now, if the therapist, if the technologist on the machine did not know this, the nurse forgot to tell the therapist on the machine, they will be calling the patient, Yalla ta'al, you have a treatment, tamam? And the patient will be confused. And he think, okay, they called me, so I really need to go and get my treatment. So you have to keep an eye. So the second checklist is really important. Therapists are really our last line of defense. They have to make sure that everything is in line. Planning parameters are matching, revisions of any plan or dose or breaks for the patient. MUs are matching, and not just for the first treatment session, but of course, before each treatment session. This is very important, tamam? And this would be, خلاص, this is the last QA you do for any plan. And this is true, by the way, سواء conventional or 3D or IMRT or SRS. This is true for all your patients in the clinic. So this is important for our radiation oncologists, for the chairman, for the chief radiation oncologist to know this and implement this. So it's kind of going back and forth. So MU verification. So now, right now it's concentrating on MU verification. Radiation oncologists, you may, check your mobiles. You may be excused. You may, I don't know, if you want to leave, you can leave. We would love to have you around, but from now on, it's purely towards the physicist. So now we're looking at MU verification. And for the physicist, this is the last step that you verify the plan quality assurance. You're verifying now the output of the TPS. The first criteria is that it has to be something separate and completely independent from your planning system. And the database that you have for this MU should also be independent, meaning don't take the PDD and output factor or the model from the planning system and put it here in your MU check software. It's always better to go back and use the output factors that you measured in the water phantom. And by the way, if you buy a software, the software itself requires commissioning. The software might only take PDD or might take PDD and TPR, or it will give you the option. It might only require SAD, output factor measurement, or SSD. So if you're buying a software, you have to commission it, of course, and you have to commission it with your own measured data according to what the software wants. The good thing about having a third-party software is that it can handle more complex cases, tamam? And most of them can handle the field-in-field issues. And the recent ones can also handle even IMRT QA. It can give you the monitor unit per IMRT field. The planning software, however, the purchase software is, the MU verification software, it is usually connected to your TPS through a DICOM export button. يعني, you push the plan towards that software. So yes, the correct wedge angle, the correct prescription point, the normalization point, the various things, X1, X2, Y1, Y2, even the shape of the MLC will transport over to that. Now, this could be a good thing. This is actually a very good thing, because manually, if you have an Excel sheet, you cannot reproduce all these complexities, especially if you have an MLC shape, tamam? Like field in field, for example. It could also be a bad thing, because some of the parameters might, again, this is computer talking to another computer. So there could be a bug that transfers from the TPS to that second software. Very low in probability, very minimal to occur, but it could occur. So you have to keep an eye on it. يعني ما في شيء، ما في حياة. There is no utopia, تمام؟ ما في المدينة الفضلى. Everything has a good side and bad side. Third vendor software, they cost a lot. So depending on the budget you have, you may not be able to buy it. However, I want to I want to tell you something. Sometimes when you talk to a vendor, give me a quotation for MU check software. Usually they try to send everything, تمام? That they give you the price for. Can do photon MU check, electron MU check, ممكن brachytherapy check, for example. So make sure that you tell them, okay, I don't want brachytherapy, for example. Electron, if you guys do electron very often, or you think you do very complicated electron cases, you might not need it, صراحة, the electron check. So vendors will always try to send you a complete package with everything, or as much as everything as possible. You try to negotiate with them and take down the least thing that you need. تمام? Now the other option, that the physicist can create an Excel sheet. And this is, معلش, the mouse is always going back and forth. Excel is readily available. It's cheap. Everyone in our computers, laptops, we have Excel sheet. I have written Excel sheet for MU calculation, for 3D programs. I have written Excel sheets for plaque, eye plaque, brachytherapy, and I've written Excel sheets for different things. So they can handle, and also, you can also write an Excel sheet for shielding calculation. So Excel sheets are really good resource, and you can use them to handle most clinical scenarios. Tamam? However, a lot of things can go wrong. First of all, you're doing manual entry. Someone is reading the plan. Okay, wedge 45 degree, I have X1 equals 5 cm, X2 12.5. They might enter things wrongly. They might switch things. So if you're doing whether it's Excel or MATLAB or whatever you have, if you're writing your own program and you have a manual entry of data, you have to be very vigilant. يعني مفتح عيونك منيح، تمام، مفتح عيونك منيح when you're entering all these data. Excel sheets are very notorious. You spend أسبوع زمان, you spend 1 week doing something fancy و colors ومش عارف شو, and then you forget to lock the cells. You have to protect the cells that are doing the calculation. طلع على PDD, you have a cell that is looking up the PDD. You have another cell that's looking up the output factors. Those cells that are doing the automatic things, you have to lock them, you have to protect them. لأنه أي واحد يجي هو مش منتبه, anyone can click on them and by mistake write over them, and then you lose the entire thing. So they're available and they're seemingly cheap. يعني من وجهة نظر القسم ولا chairman of the department بقول لك oh, this is zero money. أيوة, it's zero visible cash, but it's costing physics time. تمام. So however is your physics time is, this is how much money it's costing. And it depends how the physicist is comfortable with writing their own, Excel sheet. It could take 1 week or 2 weeks, but it's also important before you use it, whether this software or whatever you write, that you commission it. The easiest thing is always start with 10 by 10 field size. Start with your reference geometry. ظروف معايرة المسارع. So for example, 10 by 10 field size, SSD 100, Dmax, deliver 100, you're delivering 100 centigrade, how much MU your Excel sheet is giving you, or your software. And then start making complicated cases slowly that you can, still do a manual calculation with pencil and paper. So now I use 20 by 13 field size, and I have a tray with 15% blocked field, still at Dmax. How much I'm getting? I'm delivering 200 centigrade all the time, تمام? And you're looking at how much MU the Excel sheet is giving you, and then you start changing to different depths, change the energy, change off axis. And then you start looking at, okay, let's take a simple plan from the planning system and put it in this independent verification module and see how much we're getting. So there is 1 week. This 1 week is maybe to write an Excel program. And I would say give it another 1 week for what we call commissioning. Tamam? The time to spend here for the vendor, for the software that you buy commercially, depends on the complexity of this software. So also you might need 2 weeks total for the commissioning and verification. طيب مين كوثر. الآن نيجي على, this is another table, this is another important table in the TG report I want you to pay attention to. يعني الجدول اللي عملوا منه checklist ممتاز جدا. And this is a guideline على نسبة القبول. كم أقبل نسبة خطأ بين ال MU, independent MU and the TPS MU. Again, this is guidelines. Those are guidelines from the AAPM. You can use them as they are, or you can expand on them. This is table 2, تمام؟ هذاك الأول كان table 1, هذا table 2. Now we have 2 tables here. The table number 2 بيحكي calculation for homogeneous condition. يعني ال TPS تبعكم is calculating without heterogeneity correction. And now I am doing MU check. I can do MU check with something similar بالcalculation أو something different. إيش يعني مثلا؟ I am calculating in a water phantom. أنا أعتبر ال patient كله water. I'm not using heterogeneity correction. My patient is completely water. So this is what it means, homogeneous condition. وعلى سبيل المثال, I am using convolution algorithm, or I am using AAA, or I'm using CCC. For the sake of argument, let's say this is I'm using AAA in the planning system. نوع من فهذا في ال planning system تبعنا. الآن لما أنا أجي, now I want to do MU check. Am I using similar calculation algorithm? هل ال MU check تبعي نفسه يستخدم AAA or CCC or convolution superposition؟ تمام. خاصة especially if you're using an Excel sheet. Your Excel sheet is using Excel sheet is nothing more than just hand calculation. نضرب PDD multiplied by output factor multiplied by phantom scatter multiplied by collimator scatter multiplied by off axis ratio multiplied by كل هاي الأشياء بنحطها بيطلع معنا المونيتورينج. So Excel sheet is here, different calculation algorithm. This is your Excel sheet. Now, if I'm using this Excel sheet, comparing to a very simple scenario where in the planning system, it's only water, the entire patient is water, you can expect up to 5% disagreement. فبيجي يقول لك, if you have minimal field shaping, يعني field shaping, let's say pelvis, box technique pelvis, AP, a little bit of blocks, lateral also you have a little bit of block على أطراف البيم. So minimal shaping, you would get about 3%. وهذا لسه we're just assuming water patient, تمام? If you have substantial shaping, مثل الهودجكنز, if you're doing, you know, non-Hodgkin's lymphoma, APPA, very complicated shape, ولا inverted Y, تمام? Or you have a contour change. Contour change, so your patient is not a block of water. Where is the most visible contour change؟ وين أكتر شيء في جسم الإنسان لما نعالجه بيكون أكتر شيء بيكون فيه contour change هو البريست. Breast has the worst contour. Breast is really سهل الممتنع. Treating breast and verifying a breast plan is a headache. تمام? So in these cases, you would expect up to 4%. Oops, excuse me, my hand. Now, if you have wedges, which probably ممكن most of the time, 3-field rectum, we have wedges. Lung treatment, if you have 4, 5, 6 beams, you have wedges for sure here and there. You're doing some abdominal treatment, brain treatment, for sure you have wedges. Or this is like or, if you have wedges or you have an off-axis calculation point, then you can expect up to 5% agreement. تمام? So مثل ما حكى زميلنا that if you have depending on the case, that they will accept up to 5%. But you should expect كمان 2% or 3%. يعني الأشياء السهلة مثلا, if I'm doing whole pelvis, APPA, يعني I should expect around 2 to 3% على سبيل المثال. So if you're using, that's why I have it here, if you're using Excel sheet, and almost all of the vendor software اللي هم يبيعوهم الvendors, تمام, they assume it's a uniform Q phantom. There is only one software that I know of إلى الآن that actually uses the CT data set and recalculates the entire plan, including isodose distribution and DVH independently. I don't know if I should say the name or not, but يعني, that is a very expensive software. So actually the CT and the plan all goes towards that software, and the software calculates the entire plan من البداية. It uses CCC calculation, and it gives you a DVH that you can compare to your plan DVH. It gives you isodose, you can compare to plan isodose. It gives you, you know, gamma analysis. But all other softwares assumes uniform phantom. تمام? I'll come to this. طيب, I'll come to this later. Table 3 تاخدوه and you translate it to Arabic. It's actually good. Table 3 tells you that if I'm using heterogeneity calculation, so the planning system, you're using heterogeneity calculation. You have heterogeneity calculation turned on. So now look at this. Now you should expect more disagreement. As we said that we're using different calculation algorithm. If your planning system is using AAA, maybe your Excel sheet for sure is using regular hand calculation. Maybe your planning system is using Accuros and your sheet is using CCC. تمام? Usually it is a different calculation algorithm. So in these cases now you're looking at higher disagreement. But look at this. In table 3 بالAPM report, they did not put a uniform phantom. This is different calculation algorithm, approximate patient geometry. يعني phantom قريب من شكل المريض. If you are using Excel sheet or you're using something called okay ما بدي أحكي أسماء except of one calculation software, all other softwares assume a uniform Q phantom. So in this case, if you're doing heterogeneity correction and you're assuming MU check in a uniform Q phantom, you'll be getting discrepancies ممكن 8% or higher. What should we do in this case? تمام؟ هلا I have heterogeneity calculation. I'm treating whole brain مثلا. So let's take the example of whole brain. I'm treating whole brain. I have minimal block of the يعني البلوك قليلة جاي بس على الأورال cavity. I'm only blocking the oral cavity. Everything else is open. Most of the brain is water, صحيح? And then I do, but I'm using heterogeneity calculation على the planning system, and then I come and do my MU check. And I can see that I have higher disagreement. You can say, well, 5% is good enough. What about if it was 6%? مثلا? In the case of breast, you might find a disagreement between 8 to 10%. What are you going to do in this case? In both scenarios, a physicist who knows how things are done, that's why you need to know exactly these tables. These tables tell you everything you need to know. And if you know how your planning system is doing the calculation, and if you know how your second check is doing the calculation, you will probably pass these plans. And I will show you why. فناخد the whole brain as an example. تمام? So this is whole brain. I have 20 by 20 field size. About 20% blocked. تمام؟ هذا البلوك هنا. This and here. And prescription is at isocenter. And you can see that the prescription point is really far away from any beam edge, and it's far away from the blocks. Most brain is normal tissue, يعني water equivalent. فأنت you think, oh, this is very straightforward plan. I should expect 1% agreement. بعدين تعمل a second check, and you might get 3%, 5%, ممكن up to one case I had up to 6%, but usually it's around 3 to 5%. In such straightforward cases يا جماعة على مفتوح, you should expect 2%, صحيح؟ فالسؤال هو what's going on? طيب نطلع على البيم eye view. You can see that you have air. This over here is air. And this over here كمان air, صح? Air does not contribute to dose. The planning system, because the planning system is using a CT data set, it understands in a few regions, there are regions that are not contributing to dose. This is missing tissue. So what it's going to do, it's going to increase the monitor unit. راح يعطي MU زيادة to overcome what it sees as missing tissue. هو كأنه إيش حاصل؟ كأنه your second check program assumes 20 by 20 field size, كله, the entire 20 by 20 field size is incident on water. صحيح? It's assuming this. It's assuming the entire field size is incident on water. Well, water contributes to scatter. So I have high phantom scatter. So I need to have less monitor unit. يعني هو السكاتر contributes to dose, صحيح؟ فتلاقي إنه السكند MU check تديك less MU. Now, what's happening is that air is not taking into account when you do second MU check. You assume, you say 20 by 20 field size, only 20% block, and that's it. What about air? What about the shape of the brain? Even if we assume, we'll talk about it later. طيب هلا السؤال, what can you do? You have 6% disagreement. And you're scratching your head. This is a very simple case. What's going on? So what we can do, we have two options. The first option, if you're using an Excel sheet, so most probably you have to put percentage blocks, tamam? So you're saying 20% block. In this case, I am asking you to include the air as part of the percentage block. لأنه when I say this field, this part is being blocked, معناته هذا الجزء is not contributing to scatter. If it's not contributing to scatter, معناته there is less dose going to your point. You know, no scatter, less dose, تمام? So you need to increase the monitor unit. But what we do is that, okay, we say I have 20% blocked. The numbers, يعني just made up numbers, تمام? So let's say I have 22% or whatever, is just an example, 20% blocked. And then you estimate that the air is also another 20%. يعني تقريبا خمس المنطقة هذه عبارة عن هواء. So when you write the total percentage of blocked field, you put 42%. اللي هي percentage of air زائد percentage of actual blocked field. عفوا. لما when we increase the percentage of blocked field ايش يصير؟ The monitor unit will increase. صحيح؟ كل ما زودنا لأنه we're making the opening smaller and smaller and smaller. Instead of 20 by 20 field size, now I have a much smaller field. So the MU will increase for the same dose. Let's say you cannot add, percentage of blocked field for whatever reason. Play with it, يعني خلينا نقول. So in this case, I can reduce the field size. You want to mimic a smaller field. When I say 42% of the field is blocked, يعني 42% of the field مش موجود. صحيح؟ طيب, let's say I cannot change this. Let's say يعني for maybe in your clinical protocol, the percentage of blocked field should be the same as the planning system. You don't want to change it. You absolutely have the right to do so. So in this case, how can I take the air into account? أقول طيب الاير تقريبا 20% من الفيل. بدل ما ادخل على الاكسل شيت، بدل ما ادخل field size 20 by 20 ادخل field size 16 ب 16. So you make your field size smaller by the amount of air in the field. Okay? So we're trying to be smart because our verification MU, whether it's Excel or most of the vendor that we have, they assume the patient is a flat cube of water. So we have to be smart on how to let them know that part of this treatment is air. Okay, so either you play with percentage or you reduce the field size. Okay, so you do the following, and now you get 1 to 3% agreement. This is actually good. If we go back to the table, to table number 2 and even table number 3, this is good. This is good agreement. So we can say, خلاص, I'm going to sign on the plan and let the patient be treated. But let's talk about it. Why? We've done this and we still have disagreement. Why? It should be 0%. صحيح? I should get the same exact MU. Why do I still have a little bit of disagreement? الآن ما تنسى again, please don't forget that the planning, the verification software again assumes a cube water phantom كده مكعب من المي. But your TPS knows that the organ has a curvature. في عندك shape. And this shape is in 3 dimensions. يعني مثل البيضة. ممكن يكون from one side, if you look at it from the back, from the inferior part, the egg maybe looks circular. If you look at it from the superior part, it has this conical shape. So the planning system knows all this information, as well as it knows all the tissue heterogeneities in the path of the beam. So the brain is water, that's correct. But in order to reach the point of prescription, which is in the isocenter, you still have to go through bone. صحيح? So that's why your verification software most likely will give you 1 to 2, 3% agreement if even if you do everything correctly, because it doesn't have this extra information in mind. طيب, now let's look at breast. Breast is even worse. شوفوا, breast planning, when I second check a breast plan, I really take my sweet time because a lot of things can go wrong in a breast plan, and all of our brains look the same. Well, maybe shape a little bit different here and there, but the breast changes from one patient to the other, and it actually could change for the same patient during treatment. How she holds her hands up, how she holds her hands down, she's arcing her back, there is seroma, ila akhirih. So yeah, you have to pay attention for breast. But now let's look at MU verification. If you're doing MU verification for breast and the ISO center or your prescription point is here, you will easily get 10% discrepancy. يا لهوي. طيب, before we go into this crisis mode, we have something similar to brain. We have all this air. صحيح? Let's say the field size, مثلا give me field size for the breast. Let's say this is about يمكن 12 cm, and from here to here, maybe this is about 20. صحيح? For example. So you enter 12 cm and 20 cm in your Excel sheet. But your Excel sheet is assuming, again, like the brain, that the entire field size is going through water. What you're not telling your Excel sheet is that all this is air. So we should take it out of consideration. Now I do two things. When I am second checking breast using what we have in our plan, what we have in our clinic here is a rad calc. تمام? But I did the same thing when I had my Excel sheet back in Jordan. First of all, I have 3 cm flash in air. صحيح? So I remove this. So for the purpose of the Excel sheet, oops, I put the field size here. So instead of full 12 cm, بقول مثلا, let's say 9 cm. I removed 3 cm in air, I removed them. So now I put 9 cm in the x-axis. Now let me, hold on, let's erase. Okay, and go back. So the first thing for the Excel sheet, all this is air, I don't need this air. I enter the field size that barely touches, the breast. So let's say I'm removing 3 cm. So instead of 12, I enter 9. And then I estimate how much air is here. Let's say this probably is a 15%. طبعا, again, this is an estimate. It depends from one person to the other, but it will bring us closer. If you put 15% or 20% or 12% of air, هدول small values, don't be hung up on the actual number. As long as you're trying to mimic the actual treatment. So we're trying to remove air. We're trying to tell the Excel sheet that there is air there, تمام? So either use percentage of block for the entire field, or close the x-axis from this side and then estimate how much block you have here, just like we did with the brain. Now, if you do this, you'll probably go down to 6%, 5 to 6% discrepancy between your planning system and your manual calculation. Or actually could be even better. In this case would be probably better. If I correctly estimate the air here and I close the jaw, I could even have a 4% agreement. Now, in breast scenario, it's highly unlikely you will have 1% agreement. Well, you will probably have at best an agreement of 3%. Yani, anything below 5% I will consider good for breast, because remember, planning system knows that the shape of the breast, it's thin from here, and then it's very thick from here. So there's a lot of tissue here contributing to scatter. And then it goes into this weird shape where you have the breast fold. And not just from this beam eye view. Remember, the breast can move in any direction. So the shape in 3D is different. Your planning system knows this, but your Excel sheet doesn't know that. And if your point is in the middle of the breast, this is good. It's far away from, but trust me, wallah, I have seen people who put the prescription point right here, just 1 cm away from the chest wall and lung. Yani, really? So all these heterogeneities, as well as the very irregular contour and the shape in 3D, all these things that it's not taken into account in the Excel sheet. So as long as the Excel sheet gives you something reasonable. So if all this was water and all this was a uniform block, then I should expect less monitor unit. What you should keep an eye on is that your second check MU is giving you less MU than your planning system. ليش less MU؟ لأنه مثل ما قلت الإكسل شيت أو your rad calc is assuming a block of water. ما في مشكلة contours، ما في مشكلة heterogeneity. So it will assume life is good, there is enough scatter, so I need less MU. And what we're trying to do, we're trying to, keep the agreement or disagreement, 5% or less. But don't be scared when you're first time doing 3D CRT for the breast and you're getting, 8 to 10% discrepancy because of all this air flash and air that is in the beam and the Excel sheet is not seeing it. طبعا يعني to make things even worse, if you're doing field and field technique, your disagreement will be more. If you're using, well, expect disagreement to be more. You can still have a smart way. If you're doing field and field, there is still a smart way of handling this. You can assume every field is independent by itself. So this is a subfield from a medial. Tamam? This is medial subfield with these MLCs inside. We've talked about this if you guys remember I think the lecture 6 or 7. So I can consider this as a field by itself. يعني أعتبره حقل منفصل. And I enter, okay, I have this X, I have this XY. And the percentage of block, I include the percentage of blocks using MLCs أو البلوك العادية plus the air. معلش beam eye view is not clear, but you still have air here. And then, so you can consider the field and field as separate fields by themselves. And you do the calculation. It's going to take more time of you. طيب الآن long case. Another scenario where you would have discrepancy, maybe reaching up to 12%, is in the long case. And the discrepancy here is not coming because we have air in the path of the beam. يعني هو تمام skin البيشنت more or less يعني جاي خط مستقيم. تمام وبعدين كله the entire beam is going inside the patient. This one, the red beam, is also seeing, almost like a flat surface as well. The white beam is seeing a little bit of curvature. في هنا curvature خفيفة. But the entire beam is incident on the skin. Okay? Now what happens is that I have point of calculation over here, somewhere over here. And then I have a beam that goes through tissue, lung, and then, tissue again, or maybe interface, or whatever this is. الألوان مخربشة ببعض. So now the discrepancy is coming because تذكروا الإكسل sheet ولا whatever the third vendor software that you bought, most of them assumes this is water entirely. So what you need to do, you need to take the effective point into account. يعني الeffective depth. نفترض إنه الدبث الكامل, the entire depth, if I'm going to measure it with a ruler, let's say is 10 cm. تمام? That would be the physical depth, or actual depth, the one that you measure with a ruler. But because of the radiation property of the lung is different than tissue, and lung, the way the lung interacts with radiation is different. تمام? So the actual depth would be less, as if, by the way, what's the density of lung? Depending on where you are in lung, density of lung could go from 0.2 gram per centimeter per cc to 0.35 gram per cc. يعني it is 20% to 35% من density المي. So وكأنه as if and if I want to take the average مثلا, let's say average, as if lung is 25% tissue and 75% air. So there's a lot of air, not much interaction. So the effective depth would be less by whatever, would be less than 10%, than 10 cm عفوا. Okay? Your planning system can give you this information. The printout of the planning system includes the actual depth and the effective depth. And this is the depth that you want to use in your calculation when you're doing a hand calculation. تمام? The easiest way, wherever you enter the depth بالExcel sheet, you enter the effective depth. تمام? This is the easiest way. But it will not solve all your problem because there's so many things that is wrong with this. Let's say the effective depth was 6 cm, for example. This is the effective, 6 cm. I am saying that from the point of entry of the beam until the point of calculation, I have an equivalent of or effective 6 cm of water مثلا. ولكن it doesn't tell me if the prescription point is before the heterogeneity or inside it or before it. I have this case, high scenario هون, I have some heterogeneity, تمام? And I have a point here. And I want to calculate the effective point of measurement to this point. This will be the same distance, this will be the same D effective. سواء كانت heterogeneity in the middle, or if the heterogeneity was right at the point of calculation, or if the heterogeneity كانت at the very beginning. يعني D effective does not tell me how far away my point of calculation from the heterogeneity. It doesn't tell me. It could be right on top of it, it could be somewhere in the middle, it could be at the entry point. It didn't tell me. This is important ليش؟ لأنه scattering behavior is different. أنتوا بتعرفوا كل ما the closer the calculation point is from a heterogeneity, the more it is affected by the scatter property. صحيح؟ يعني كل ما اقتربت نقطة الحساب من المنطقة مش المي تتأثر أكثر بالسكتر اللي عم بصير أو lack of scatter يعني عن المنطقة هاي الهيتروجينيتي. لكن هاي المعلومة مش موجودة في الدي effective. يعني هو يدي لك دي effective and then you just have like 6 سنتيمتر هو دي effective. What happens even if you do this, even if you account for the effective point of measurement, you will still have around 6 to 8% discrepancy. As long as it's in the correct direction. مثلا you expect الإكسل sheet تعطيك MU أقل and you apply the D effective correction بشكل صحيح. You took into account any air موجود ولا blocking موجود ولا off axis ratio and you're still getting, let's say 6%, I will accept it. بناء على شو? You might ask me, why would you accept that? Well, بناء على هذا الحكي. If I'm using heterogeneity correction and I have low density heterogeneity, تمام? I should expect 5% agreement. هذا على فرض شو؟ على فرض I'm using patient geometry. But I'm not using patient geometry. I'm using uniform cube phantom. هو الإكسل شيت تبعك إيش بيعتبر everything is uniform cube. The AAPM, for some reason, they did not put this column here. So if I am using approximate patient geometry مع heterogeneity correction, I am allowed to 5%, up to 5%. So let's say my Excel sheet is, or my RADCalc or whatever, is assuming it doesn't have patient geometry, it's assuming cube phantom. So if I'm getting 6% agreement, I will consider that okay. تمام? Only for certain specific cases, and only if you are sure إنه heterogeneity is what is causing the disagreement. الآن, if you're still not comfortable, let's say the protocol in your clinic tells you no more than 5%. يعني إيش ما تعمل أكثر من 5% we will not treat. Okay, in this case ما في مشكلة. Hold on. Okay, I will tell you what you do in this case. This is an example of one of the third-party vendors of, and this is something very simple, أجزلة. تمام؟ يعني الأجزلة شو بدك أسهل من هيك. What you have measurement depth تقريبا 7.2 cm, and this is the effective depth. Effective depth is 6.9 cm. Not too many heterogeneities بالأكزيلا. في عندك هون كمان, this is posterior part. This is two field axilla. عندك ال physical depth 10.5 and ال effective depth 10.27, 10.3. By the way, يمكن واحد يقول يعني difference is 3 millimeter. We're going from 10.5 to 10.27, يعني 2-3 millimeter. It's not a big deal, صحيح? But look, even with these simple scenarios, I already have a 1% difference. And notice what I said. Your Excel sheet, oh, I'm sorry, your Excel sheet will always give you monitor unit that is less than your planning system. ليش less? Because the Excel sheet always assumes, or in this case, the RADCalc always assume it's a block of water. تمام؟ هتقول لي طيب احنا we took effective depth of measurement بعين الاعتبار. Okay, so we've taken depth of measurement into consideration. But as I said, the effective depth of measurement doesn't tell you where the heterogeneity is with respect to the calculation point. كل ما كانت calculation point قريبة من heterogeneity, it is affected more by the scatter condition of this heterogeneity. And if the calculation point is far away from the heterogeneity, it doesn't really, يعني ما تفرق معاها. But you don't know this. So even with this very simple supraclavicular example, I'm getting 1% difference. تمام؟ طبعا again this is acceptable. احنا بس but يعني don't feel disappointed that you're not getting 0%. You're not getting exact MU match because of all the, and this is a third-party software that really costs a lot of money. And as you see, it's doing like what we do in your Excel sheet, or like what you do, you know, it takes into account collimator scatter. This also takes into account blocking, inverse square, if you have a bolus or without bolus. And in this case, ما في bolus, in a zero. SSD at isocenter, and you also have SSD at calculation point. They're almost the same because it's the same, almost the same point. So even with a simple case of a supraclav field, you have this 1% discrepancy. What you should keep an eye on, that your MU check will give you less monitor unit than your plan. Your plan is always compensating for the presence of air, is always compensating for the presence of heterogeneities, it's always compensating for the presence of contour. عاوز دائما يعطي MU زيادة علشان هو عارف إنه في هواء، في heterogeneity، شكل الكونتور مختلف. فدائما what you should keep an eye on, MU from your plan should be more than the MU that you do second check with. يا حبذا نفس الشيء. تمام؟ Okay. So now let's go back to the question of, you know, your clinic protocol. طولنا عليكم بس يعني this is really في لب الموضوع. Let's say your clinic protocol does not allow anything more than 5%. And in this lung case, you got 6%. You did the D effective, you did everything, and you got 6%. So what can you do? And your protocol says don't treat if you're not within 5%. You have two options. You can copy the entire plan into a cube phantom. تمام? If I copy the entire plan into a cube phantom, and then I do a second check على this plan, I should get agreement within 1% or even less. إنه 6% هاي جاي نتيجة the entire heterogeneity is هنا. Lung is really crazy, right? Especially in this case, if the prescription point, if you إذا تنتبهوا, pay attention, the isocenter is right there at the interface between the aortic arch, تمام؟ هنا التissue and the lung, and this is not where you're supposed to put your prescription point. ده خطأ. However, this is an IMRT plan, so it doesn't matter. بس يعني you have to really pay attention where you put your prescription point. Please اتذكروا the ICRU lecture that we took together. تمام؟ But one way to make sure that the discrepancy you're seeing is due to heterogeneity, مش due to bug from a computer ولا bug from the plan itself, is to copy a plan, حطوها على water phantom, recalculate, and then you should be able to have the exact same MU. And then you can say, this is 6% is due to heterogeneity وأنا 100% يعني sign on this. Of course, the gold standard is always measurement. الناس اللي بيعملوا IMRT مثلا, you do the same process, okay? You take the plan and you put it on your measurement tool and you deliver it to the machine and you should be able to measure the dose within plus minus, يفضل plus minus 3%, okay? But you can give yourself up to 5% if you investigate. So if you try to do all these tricks and your MU is still more than 5%, you can, copy to a phantom and you can always perform measurement. بس مثل ما حكينا, if you go back and you use these tables, تمام? Table 3, table 3 is what you will be using if you're doing heterogeneity correction in your planning system. But pay attention, the numbers that they give here, 3.5% and 4.5% and 5% is if you have approximate patient geometry, which we do not. So you have to increase your numbers more. يعني this could be 6%, this could be 5.5, this could be 4. يعني أعطوا نفسكم زيادة شوية يعني you're not using patient geometry. Second, checking a plan is an art. يعني it goes beyond looking at numbers. You have to يعني sit down with a good يعني cup of Nescafe or coffee or your favorite beverage and make sure that before you sign off on a plan that you've done second check with, everything meets the criteria. Again, depending on how your clinic is run and how that clinical protocol that you put in your clinic, if you cannot, if you don't like the isodose distribution, you don't like the DVH, you should always go back to the doctor and should always go back to the planner who did the plan and discuss with them. The second checker, the physicist, you're not just wasting your time or doing something redundant. The second checker has a very important role to make sure that only good quality plans and plans that can be delivered go to treatment. Okay, as I said, what are we doing? We're not trying to get the same exact MU from the TPS. Our role when we do the MU second check is to make sure that there's no gross error in the calculation. ما في خطأ فظيع, ما في, no one forgot something. You're not overdosing the patient. If you do the MU check, and from the beginning it gives you the acceptable tolerance. Again, acceptable tolerance should be dependent on the clinical protocol that you have. تمام. يفضل إذا استخدمتوا ال APM report as a reference, that would be very good. Then you can go ahead and treat. If the agreement is outside tolerance, let's say your protocol says 5%, 5% is the maximum we will agree. Then you have to find out why. And again, you have to remember that your second check method, is it assuming patient geometry or is it assuming a cube phantom? What does it do with air? What does it do with heterogeneities? So you have to look into all these things, and you as a second checker physicist, you have to make all these corrections now to the MU. What you're trying to do, you're trying to bring the agreement in the tolerance level, tamam, 5%. If you do all these things and the MU is moving closer towards agreement, then it's okay to treat. In the case that you've done all this problem solving and you're still outside agreement, 6, 8, 10%. Well, if you have 10% disagreement, I would press the brake and say, please stop. You have to tell the physician and the planner, especially the physician, that we cannot start treating this patient. You can't, because you don't know if this 10% disagreement, is it from the planning system itself, so the MU are actually wrong, or maybe they are from the second check itself. Now remember, second check could also have errors in it. So you have to investigate both your TPS and your second check. I would suggest another look, maybe someone else to take a look at the plan for prescription point. If I noticed that, and this is what happens with the breast cases, is that when people use field and field all the time, they put the prescription point, and it's okay for the actual open beam and maybe the first or second field and field, but then the third field is so modulated, it's so blocked that the prescription point is covered. It's under the block for the third beam. And that's usually what happens most of the time. In this case, I will ask the therapist, the planner, to open the beam a little bit, open the fields a little bit, or choose a different point. Last resort, you try measurement. Measurement is the gold standard. Tamam? As I said, you can, if you want to make sure is it heterogeneity related problem, you take the plan, put it on a water phantom, recalculate, and then see how much agreement you have. Last but not least, you try measurement. If you still do not have an agreement that is within your clinical protocol, then maybe there is something really wrong with the plan itself. And sometimes, like once every 10 years, you take a plan that doesn't really make sense, some bug into it. What I suggest you do is that you delete the entire plan and you start from the beginning. You start from importing the CT data set again, doing everything again, putting the contours, etc., and replanning. I think I've done that only once with a brachytherapy case, where we were not able to solve the issue. We redid the plan, but on the same CT data set, we were still getting the wrong, our tolerance was outside the expected value. And what we had to do, we had to delete everything and start over again when importing. And for some reason, that solved the issue. So it could be just a bug in the system for that particular plan. You don't really know how computers. It just happened to me once in a brachytherapy case, but it never happened to me in an external beam case. But again, you might need to to replan often. It's very important that if you're not reaching the tolerance level set by your clinical protocol, that you should not treat the patient. Take home, I guess everyone now understands that 3D CRT requires more time, not just for planning and contouring, but also more time for plan QA. And please don't forget that radiation therapists or radiation technologists, they need to have their own checklists to QA the plan. Please write your own clinical protocols, making sure that you include what are the levels of agreement you have. And then, physicists have the daunting task, and really it is a very difficult task, because once you sign on that plan, then you're allowing the patient to go on for treatment. You have to make sure that the second check for the monitor unit is also performing properly. I listened to reports of the AAPM. One of them is talking about this. I summarize it here, which is how to handle discrepancies and talk about discrepancies of monitor unit calculation and the errors that could happen. And the other report basically كله is MU calculation method. يبدأ معك من الأشياء simple وبعدين you go into more and more. And they have the whole brain case. I'm not sure if they have the breast. It's been a long time لما شفت البروب. But I know they have the whole brain case موجودة. How to do MU calculation for it. And this is it. أي أسئلة? Anyone has a question? I am all ears.
Yeah, there are a few. Thank you very much, Dr. Shada. May I add also that sometimes in field cases where you have very small number of MUs, you can also end up with high percentage discrepancy, but it could be just one MU, right? In which case you would accept.
Really a good point. صحيح. Hold on. How can I get out of this? Discard. طيب, this is a very good point to make. خلينا. So sometimes you see a percentage discrepancy. مثلا يقول لك 20%. Oh my God. OMG على رأي بنتي. 20% discrepancy is too much. But if you have very small monitor unit, if the entire monitor unit for this beam is 5 MU, تمام? And your second check is calculating 4 monitor units. 1 من 5, this is 20%. And ومثل ما سارة حكت, this comes when you have the field and field, because sometimes your field and field is only giving 5 or 10 MUs or something like that. Even if I say 10 MU, I have the third subfield يديني 10 MU, but the second check is calculating 9 MU. Then the discrepancy here is 10%. In this case, this is important. In this case, يا جماعة, then the percentage is not real. تمام? لأنه رقم صغير تقسيم رقم صغير يعني it's a small number divided by a smaller number. In this case I can say the difference is in absolute units. So I can say the difference is 1 monitor unit. Here the difference is 1 monitor unit. So you can have your clinical protocol to say we accept no more than 5%, for example مثلا تمام, or no more than مثلا 2 MU difference or 3 MU difference. To give room for such scenarios where you have one field that is contributing very minimal monitoring. This is very important. شكرا جزيلا.
It's my pleasure. Masoud Izdragi, I think, has a pretty long question. I don't know if you want me to read it to you or if you want to read it in the chat box.
If you can read it, لأنه I am...
Okay. If you have a locally advanced head and neck tumor and PS of the patient is 3, your aim of radiotherapy onset and prescription was 30 gray interfractions. After finishing this,
what's PS? I'm sorry. I found the question. What's the PS? What's PS? And PS of the patient is 3. إيش يعني?
I do not know actually. Masoud, do you want to clarify? But I don't think it's very relevant to the question that he's asking. So he's basically saying you completed that course of 30 gray per interfractions. And then because the patient has good response with acceptable tolerance, you decided to complete the treatment up to 70 gray. So they're changing the prescription, sounds like. For this case, does it need BED and EQD2 and recalculation and MU's verification? And what else?
Okay, طيب, Masoud, this sounds like a real case scenario. So yeah, you're going from a regular fraction, you're going from 3 gray per fraction, صحيح? You have 3 gray per fraction times 10 to a total of 30. And then you want to continue to 70 gray. I would assume 70 gray will be delivered in 2 gray per fraction. Yani 20 fraction times 2 gives us 40, and you add them to 30 gray. Yes, I would use BED. But this, I know physicists are always asked to do BED, but eventually the physician has to approve it. إيش الألفا over beta use for your head and neck tumor؟ إذا سمعنا مسعود، إذا بعده موجود. طيب okay, whatever. Yes, you need to do في موضوع MU verification for every plan, regardless if it's a boost plan, electron plan, or you're just, conventional plan. You always have to do MU verification. There is nothing else you do here. يعني ما في what else, عرفت? You do MU verification for your new plan. And by the way, planning system تبعك, the planning system تبعك will add up the physical plan, physical sum, مش ال BED. And even if your planning system, I think Monaco can do a BED. Even if a planning system can do plan sum with BED, please do not trust it. لأنه ال BED depends on alpha over beta ratio اللي really until now we should take it مع علامة استفهام كبيرة. تمام? From the physics point of view, once you finish your plan, you have to do monitor unit verification, and you do plan sum with the old plan. What we can give to the physician, plan sum of the physics dose and MU verification. هلا انت BED, you're going to calculate the BED وكذا, but it's going to be the responsibility of the clinician to tell you the dose fractionation للبلان الجديدة. But as a physicist, you do the plan, then you do the plan sum, and then you do the MU calculation for the new plan.
Thank you. Now, next question is from 02210. What's the name of the software that does not use potential coefficient geometry?
M3D أظن من موبيس, شركة اسمها موبيس.
Yes.
Yeah, صح سارة.
I would just say Mobius. Yeah.
Mobius. Yeah. So basically what happens بهذا السوفتوير, you send T تبع البيشنت للسوفتوير, والسوفتوير it takes about ممكن 5 minutes بيحسب لك البلان كاملة, الisodose distribution مع DVH, and it compares it to your TPS plan. So in this case, if you have this software, if you have Mobius, or a software that is doing second check based on CT dataset, and it uses CCC, by the way, it uses CCC. In this case, you will be applying these parameters. هذا اللي هو same patient geometry. إذا أنت بتستخدم planning system that has triple C as well لأنه Mobius uses triple C, then you will use this 2%, 2% and 3%. Then you're using similar calculation algorithm and you're using same patient geometry. So you'll be applying these tolerances. إذا أنت بتستخدم planning system مثلا then you apply اللي هي هاي اللي هي same patient geometry بس different calculation. تمام؟ So 2.5, 3.5 and 4. So يعني in this case you don't have to worry. You should have very good agreement between, and we have been using it يعني for the last few months and it really gives good agreement between the planning system and the second check.
And Mobius gives you also gamma analysis, right? So you look both
صحيح.
at the analysis.
Yeah.
Okay, Mayada's asking, I think it's not clear to her what the effective depth is because the question is Dmax يأتي بعد D effective. هل Dmax يأتي بعد D effective؟
البلاننج سيستم لما يديكي الدي ماكس حيديكي اياها من الانتري بوينت. هذا حسب البلاننج سيستمز انا اشتغلت عليهم او فيهم. So you need to know your planning system. Usually هو يقول لك هيطلع لك الدي افكتيف للدبس تبعك. فاذا الدبس تبعك يبدا من السكن يعني هي
May I sorry ميادة الافكتيف ده هو الجسم وكأنه مويه، يعني لو كان عندك مويه الفيزيكال ده how do I put it؟ هو بالعكس في الهواء حيكون ابعد، الافكتيف ده حيكون من الفيزيكال ده. لو عندك عظام يبقى اقصر وهكذا.
That's correct.
يعني الدي افكت يعني يعني بيصير بيها يعني
بقولي مثلا عندك نقطة معينة على بعد 1 سنتي من السيرفيس، اوكي؟ حيكون هي مش او الدبث في الحالة دي فيزيكال دبث حيكون اطول.
يس فهمت.
I'm just writing something. طيب ما
وقع.
احنا فين نستخدم الدبث بالكالكوليشن في المونيتور يونت؟
الدبث
ايوه
هو بالايزودوز يعني
بالكالكوليشن تبعت المونيتور يونت. when you do manual calculation يعني تعملي بيدك calculation للمونيتور يونت فين تستخدم
التي في نفسه يعني